Welcome, everyone. Thank you guys so much for spending your afternoon, evening, whatever time zone you guys are. We are so fortunate to have the amazing Joy here today. Kind of give her perspective about play and development. And we're just really here to learn what Joy has to share with us. And a few of you guys have asked, but once the webinar ends, I will send a follow-up email. And if you are interested in receiving PDUs, please be sure to respond to that email. It will have a link where you can submit the request. So without further ado, I'm going to hand it over to Joy, and she will lead the way.
Thank you so much, Sunny. Can everyone hear me okay?
I can hear you great. So
Okay, great. Thank you so much. Let me share my screen here. Actually, let me see if I can present full screen. Um, hmm. Let me share my screen first. Can you see that okay? And then if I hit present, can you see the full screen presentation, Sunny?
it looks perfect.
Okay, perfect. Hi, everyone. Thank you so much for joining me today. I wanted to touch on a very unique subject. I have many different interests within, not only within the child life profession, but also outside of the child life profession with children. I write and illustrate picture books in addition to being a child life specialist. And so I wanted to share all of the knowledge that I have learned in the publishing industry and how I create these educational materials that are developmentally appropriate for children, adolescents, and families. And I wanted to touch on the process of what it's like for me to collaborate with the interdisciplinary team and to receive feedback from the families as well as the patients themselves so that I can continue improving the educational materials that I provide for these families that I serve. And so today we're going to be talking about child life interventions, about diagnosis and treatment, specifically for educational material geared towards children and adolescents. And my name is Joy Nicholas, and I have been a child life specialist. I've been certified for almost 7 years. I have been practicing for about 5, 6 years, and I serve a very unique population. And I'll talk a little bit more about that. My current role as a child life specialist is I serve the CAR T cell therapy, which is under the umbrella of cancer cellular therapy, which means that I provide support for clinical trials. And those clinical trials are within oncology diagnoses, one of them being DIPG and DMG, and which is a terminal brain tumor, and then the other being children and adolescents and young adults who are affected by relapse leukemia and solid tumors. So I work within this very small clinical trial team, and most of their training is in the adult world. And so I bring a sense of pediatrics and child-friendly, family-centered care to this work in clinical trials. Right now, I function as an outpatient and inpatient child life specialist. So I work with patients outpatient for their procedures in radiology, in surgery, and then I continue to provide support for these patients when they're inpatient throughout their long hospital stays, and throughout their PICU stays as well. So I am all over the map, all over the hospital. Um, and I have been so fortunate to have this role within clinical trials. I feel like it's very unique. It was a role that was heavily advocated for by the CAR-T team. Um, and I would create these educational materials for researchers and for the physicians to also know what language to use while interacting and supporting patients during their clinical trial. And sorry, I'm not keeping track of questions, but feel free to ask questions throughout, and then I'll take questions at the end. Today I'm going to be discussing the educational interventions I provide for this unique population, the contribution of caregivers and patients, how I receive their feedback so that I can continue improving on these educational materials I provide for them, as well as the team, the interdisciplinary team, and how I collaborate with the interdisciplinary team to make sure that the medical information is accurate, to also be flexible with how the clinical trial is being conducted, because during the trial, it could change at any moment. There was a period of time where the trial had included chemotherapy, and then the chief physician had removed chemotherapy for a short period of time to see if chemotherapy made more of a difference, and it did. And so they implemented another kind of chemotherapy to the clinical trial. And so it's really about being flexible with the interdisciplinary team to provide accurate and honest information for these children and families. And then how I create educational materials myself, um, and what my process is in terms of text as well as visual pictures. On any given day, I am providing educational interventions throughout my time at the hospital. There are many different times that I'm providing education and facilitating teaching for patients, for families. And I'm very fortunate that the team that I work with sets aside time for me to facilitate diagnosis and treatment teaching when the patients are being consented to enter the clinical trial. And this is typically a very long appointment, and it's an opportunity for families to ask questions about the trial, um, the outcomes of the trial, and also the details of what is going to happen throughout the trial. And during that consent, they also talk about risks for what they're going to be entering into, what their hospitalization looks like, what all the risks for all the medications look like, what the risks for the infusions look like, which can seem pretty jarring for children, for adolescents, and for young adults even. And so I have found that it is most helpful for me to be included within these consent meetings to discuss diagnosis and treatment with the patient while the team is with the caregivers and with the families discussing all of the details of the clinical trial. And so I have the opportunity to be with the patient at that time, get to know the patient, understand where they are. And most of the time, I have time to even check in with the families ahead of time to hear how they describe certain diagnoses, how they describe procedures, how a child has coped with hospitalizations in the past. And and what the family would like for their child to know for really sensitive diagnoses such as DIPG or DMG. It's tricky because I definitely want the family to be involved in how much their child wants to know. There are some families that really want to protect their children about knowing how terminal the diagnosis is. And then there are other families that are so honest and upfront about what their child is going to go through. And so I see um, different families that want different teaching methods for their children, which is fair. And so I I provide support during that time. It's usually about an hour, almost 2 hours during that consent meeting. And then I also am present for procedures in the outpatient areas to explain and prepare children and patients about what is going to happen. Most families want explanations in doses because there is so much information that is poured into what they need to know. And so I often provide information in doses and we focus on what is happening on that day. So, for example, for for patients that are consented into the trial, they first undergo apheresis for cell collection, which means at the hospital that I work at, they have a jugular line that is placed, and I usually meet the patients within the surgery area so that I can explain to them what line they're going to wake up with, how they would like to be supported during their induction, whether it's with mask or IV, and and then what they can expect when they go to the room and what cell collection looks like, what the sound of the machine looks like, what they can do during the procedure. So I touch on all of those things and I focus strictly on the cell collection at that time. And then the next time that the patients come, because all of their appointments are pre-scheduled ahead of time, we prepare for infusion day, which also means a month-long treatment after being given CAR T cells. And so I provide a lot of preparation for what infusion day looks like, what that procedure looks like, and also what the upcoming days may look like, how they may feel, what lines they're going to get throughout treatment. And we continuously talk about that throughout their hospitalization. And I continue to prepare them throughout their hospitalization because they have to get an MRI at the end of their month-long treatment. And then they get discharged and then they come back almost every month to continue getting CAR T cells. And so there are many opportunities for me to provide educational interventions, which is why I wanted to have one single place where I can have all the information for not only patients, families, but also the interdisciplinary team so that they can see that the language that I use that is developmentally appropriate for these patients. And so after I've created educational materials, I like to obtain a lot of feedback from caregivers and patients too. And so I'll show you what an educational material looks like from what I've made in the past. But I wanted to talk about how much they contribute to how much caregivers and patients contribute to this process. Because, of course, like any other child life specialists, I like to understand each individual family's preferences on language. If the family is Spanish speaking, or if the family speaks a different language, then I always bring in an interpreter to help explain like the material that I have. And eventually, I would love for all this material to be translated into Spanish as well. So I like to present these educational materials to caregivers first. I know there's not always time for that when you're in the moment and you're going to a procedure or quickly preparing a child for a procedure. And so I sometimes even have the nurse coordinators send it to families ahead of time if they are asking for what types of materials we have for children and for teens and adolescents. Um, so I send it to the nurse coordinators so that they can also provide that information, and then they could let me know, the families could let me know what types of language they use to describe cancer, to describe tumors, to describe a variety of different procedures and how their child copes within the hospital environment. And then I always give caregivers an opportunity to provide feedback. There are some caregivers that are very gracious and offer their feedback about how to change it for their younger 4-year-old child who is learning certain topics and concepts in their school, and how it may resonate better with them if I use this language versus this language. So I really like hearing from the caregivers themselves. And also, I feel so fortunate that I can like edit it too, so that if a family really wants it to be changed for their own child, then I can also do that for them. And then for patients themselves, so for the children and the adolescents, I always take their lead while explaining the educational material. If I can see that a method of explanation is not resonating with the patient, I pivot and I'm very flexible with it. And there are some patients that like hands-on teaching, and I think that's great. And so I bring in different like educational items and play so that they can learn by doing. Um, and then allowing patients to provide feedback as well as caregivers. Does anyone have any questions so far? Great question. What is your approach with autistic patients? So I like to always take the lead of their parent, of their caregiver, as I mentioned, and I like to hear from the caregiver where their child is at and what sensory needs they have, and then adjust my teaching from there. So there are some children who have developmental needs that like to learn in a very sensory way. And so I don't use like educational books for children with autism, or I don't use certain words that can potentially trigger them. Hope that answers your question. Thank you for that question. These education books are given to families. How do you keep up with costs for these items, or is it just being printed off? So these education books that I have created for my specific population, they are being funded by the the study to be printed. And there are other ways that I've provided this too. Like I have printed them because I made them. And so I have printed them off and given them to families. But fortunately, the physician and I have worked together so much on these educational materials that together. And so she wanted them printed in a hard copy for families to have and to take home. Um, wow, there's so many good questions. We have a family who will not let us use the words cancer or leukemia with their child, 8 years old. What do you do with a family who is not receptive to education? That is the most popular question I've ever heard, I feel. There are so many families, so many families that just don't prefer or culturally they don't they want to protect their children and they don't want to mention words that could be perceived as scary, like cancer or leukemia, which is totally understandable. Every family is so different. The way that I have approached this situation, particularly, is I have talked to the family separately from their child, and I have asked them, what do you think your child knows about what is happening to their body? And then and then the families are very comfortable with telling me typically, like they know that they're sick or that they have to come to the hospital often, which is all very normal. And I validate like where the caregiver and the family is at, and let them know that honesty is the best, especially for long hospitalizations, and that I will always take the family's lead. It's a balance because ultimately, for the 8-year-old child, they may see how that lack of education affects the child in the future. And and they may have really important reasons why the family may have very important reasons why they're not mentioning cancer or leukemia. There was a family that I had worked with a 12-year-old girl, and mom pulled me aside and said, I don't want you to mention cancer, oncology, nothing around those words. And she's 12 years old. She can read. The whole unit says oncology. And all of the staff are wearing like Childhood Cancer Awareness Month shirts, you know? And so I told mom that, and mom said, I just don't want her to know because when she was diagnosed with her brain tumor, her best friend died of a different brain tumor on the day that she was diagnosed. And so I don't want her to think that she is going to die. And I really, I really felt for that mom. I felt like it was so understandable why she didn't want to tell her child at that moment. And I worked with the mom to do like an expressive activity with her 12-year-old child. And while we were making like slime, I asked her daughter, why do you think you're here in the hospital? And she told me that she has cancer. And she said it in front of mom, and mom started becoming very tearful. And I think that it's important for families to see how much their child knows because then it really like allows them to really start processing how they can continue to talk about these very heavy topics with their children. Thank you for that question. So sorry. That was a very long answer, but thank you for that question. I feel like I encounter this many times. So, can you speak about experience where a family preference was no education and declining support? Yes. So if a family wants absolutely no education, no support for their child, that is okay. They can say no to me. I am okay with that. And I feel like most times, families are very open, especially with patients that have been diagnosed with terminal brain tumors. I feel like a lot of families are very open to support, and if they do decline support, that is their choice. I always feel like as a child life specialist, we should be giving them agency and a choice to say no, and that is okay. And when they are ready, then they can let us know. Um, are these books that you've written? Yes. Yes. These two materials I'm going to talk about. Yes. Um, I have written them and I drew them. How often do you find yourself making changes to your resources to meet family feedback? And what's the turnaround to getting these books changed to and provided to families? So I don't find myself changing very much, which is nice. I receive a lot of feedback from families and patients, and um, occasionally I get feedback, and I I just go into my InDesign and I change the words based on what the family would like for themselves, and then I print them out a new copy, which is great. Um, I was a couple minutes late, so I don't know if you addressed if you only work with pediatric patients, if you work with children of adult patients. Oh, if you work with children of adult, what does that support look like? I recently started working with children of adult onc patients. I work specifically with, well, pediatric patients, and I also work with many young adults, many young adults, and sometimes even adults within the study. And sometimes the adults that I work with go to the adult side, and then I can no longer support them um, because I sit in the pediatric realm as a child life specialist. However, I do support adult patients that are within the pediatric hospital. Oh, can they be purchased and from where? No, actually, they cannot. They actually don't even have my name on it. So this is specifically for the clinical trial that I work. And if you would like a little sample, I mean, apheresis, I feel like happens in many different places, but there are there are so many different nuances for every hospital. Like some hospitals don't have a jugular line. Some hospitals do femoral lines or IVs for apheresis and cell collection. And this is specifically catered to the clinical trial that I work in. Are your educational resources available to other child life specialists? Everyone's so kind. Thank you so much for asking. No, not right now. Unfortunately, I've always dreamed of making like educational resources for child life specialists, and I would love to be able to do that, but I think I would have to start within my hospital first. There are so many different, I'm going to talk about it later, but there are so many different mentor texts and different resources where you can get amazing educational books. Like if anyone knows, I draw childhood cancer. I think that he is phenomenal. He's actually a dad of a child diagnosed with cancer, and he draws and writes the books about cancer diagnoses, or even like my port, and it doesn't necessarily say anything about cancer. The child on the front cover does not have any hair. However, like all of the information itself focuses specifically on a port and what a port does for a child, and it's so developmentally appropriate. I'm going to put it in the chat. Um,
And then I think just for the sake of time, maybe we'll
yeah,
save the last like 20 minutes for questions and then Julie,
yeah,
awesome.
totally. Thank you so much, Sunny. Um, Everyone is asking so many good questions. I'm going to keep going about materials so I can talk about my process and how I created these materials, and then hopefully I will have answered a lot of these questions already. So these are the two like big educational materials I've created for the clinical trial, what is apheresis, and then I came up with an acronym with the physician about what to call CAR T because I let the physician know that I'm not sure if chimeric antigen receptor T cells is really going to resonate with children. And so we changed it to courageous, amazing, radiant T cells. Um, and then it talks about like how T cells are made. And it really talks about in a very concrete way, like what T cells are. Um, Okay, so I always start with collaborating with the interdisciplinary team, the physician. The physicians are the ones that approve these educational materials, which I'm very grateful for. The clinical research manager provides the production of the educational materials. So, like I mentioned, these are hard copy printed for the study. The physician assistants and the nurse practitioners provide feedback. They are the most helpful in providing feedback, especially for certain procedures, such as infusions. Like for patients who are getting CAR T infusions, they have to get it through their Ommaya, um, which is like a port on the surface of the head. And and so they have given me so much great information and even so much good language that they use to describe all the different parts of the procedure itself. And then the nurse coordinators, I always ask them for feedback. And like I mentioned, the nurse coordinators are my saving grace to like send these materials to families ahead of time. They're the ones booking all the appointments for the patients. And so, such as the consent meeting. And so they are the ones that are really informing families about child life services. And it's so great. It's so great to know that families know a lot about what I do ahead of time. Um, Creation of materials. So, um, when I create materials, I always start with the support of the medical team. I write down all the medical information that um, need to be included that is concrete for children and is honest for children to know throughout their treatment. And then I create content and manuscripts and a manuscript for the actual book. And again, I always rely on the medical team to have that foundation of medical information. Um, and they would send me studies to like look into. It is so helpful to have medical team to help provide all this information too, so that I could break it down in a digestible way and in ways that are developmentally appropriate for patients. And then I build up to more complex concepts and talk a lot about procedures. And during the materials, the educational materials, especially when making them for patients, especially if it's a book, sometimes all the patient needs is a one pager, and that is okay. Um, I like to focus on the patient census, who they will see, what they will see, in what orders procedures will happen may happen. And then really making it open-ended for how they're going to feel. Like this is how you may feel, and everyone feels different. So you let us know what it feels like for you. And then the second part of that is, of course, using soft, honest language. That is a lot of our education within the child life realm. So translating a lot of these really complex concepts into ways that patients are going to understand at any age level. Um, and for older teens as well as young adults, there are also there's the BMT Info Network, which has this great and wonderful and very educational book about CAR T cells specifically, and they also have it for bone marrow transplant. So, highly recommend. Um, and so I like to use that as well, and I order copies specifically through BMT Info. Um, so I For me, I allow the educational material to guide my facilitated teaching. I don't let it be like the end all of what the patient needs to know because again, as you're facilitating teaching, you're pivoting, you're noticing cues of the patient and you're trying to understand where where they are developmentally and also how they learn. Um, so there's so many things going on within a facilitated teaching. And then creating content that provides opportunities for patients to ask questions. So like I mentioned, saying phrases like, let us know how you may feel. Everyone feels different. And then they can ask questions about what other children have felt before, things like and then, of course, include visually appealing images to patients of varying ages. So in addition to having my master's in child life, I also have a certification in children's book illustration. So I feel very fortunate. I draw the images myself. However, there's so many resources that a lot of the Charlie specialists that I work with use, like Canva, stock photos. And then there's also like getting through your hospital marketing um, to have everything approved and to use photos that hospital marketing already has. Um, so there are so many different areas to to like source a lot of these images. And then see mentor texts or books. And so for these two books that I created specifically, I used a lot of mentor texts such as, excuse me, um, I used mentor texts such as I Draw Childhood Cancer. Um, there is an organization called Family Core. The Charlie specialist is Adrienne. She's so lovely. I know her from my internship, and they have great books. And one book is about leukemia, and then the other book is about bone marrow transplant. Um, yes, Family Core, I believe. Family Core Network. Oh man, I have to look it up. But if you're really interested in it, email me and then I will let you know what it is. And I'll let you know what books that I have used to just kind of like see what other Charlie specialists, other professionals' language has been around these topics, and see how things are phrased and structured so that I know how to appropriately put information in ways that makes the most sense for patients. And then there are so many other resources, such as UC Davis has the greatest one-page resources for like supporting your infant in the hospital or supporting your school-age child in the hospital. They have such great one-pagers. I know that there are so many more in different hospital settings, and so I utilize a lot of those to help guide what I'm going to create. Eventually, I would love to make one-pagers for the hospital that I work in so that um, it's a lot more clean and digestible for all families, especially with so much information that is being included. And so I wanted to show some examples. So, I mean, for many child life specialists, we always start with cells. And so cells are the building blocks of the body. Each cell has a job. And then I talk about a white blood cell's job and how T cells are a kind of white blood cell. And they are an expert in in fighting all kinds of invaders. I talk about how some kids have invader cells in their brains, and then talking about what the brain does, and then how the doctors may have found these invader cells in your brain, and that means you have to go to the hospital for different tests, blood tests, taking pictures of your body, drawing, walking tests, and then it goes on to describe like the people that they're going to see, the procedures that they're going to experience, and how their hospitalization may be like, or how they may feel throughout their hospitalization because of these like procedures. Like they may feel tired or nauseous or and so all this information was approved by the physician before printing. And so there was a lot of editing that occurred so that we can make sure that everything was in there. And it's about, I think it's about like 17 pages. So for this book in particular, which focuses primarily on diagnosis and full treatment. And then the apheresis one focuses on cell collection. And then I'm currently working on a port one. Okay, and now questions. Is that okay, Sunny? Okay, great.
That sounds
Um,
great.
okay, great. Thank you. Let me go back to see. Mhm.
And I think I just want to chime in. I'm
Yeah.
not a child life specialist myself, right? I'm a behavior analyst and I primarily work with children with autism, but so much of the stuff you shared, like, resonates with me. Getting that parent buy-in, the collaboration, I think that's so important. And as I saw a lot of the questions in the chat, I think, as someone who's been in my field, right, working with parents who have autistic children, working with autistic children. I think a lot of the stuff that Joy shared, really talking to parents, like what are the languages that are comfortable. I've had parents that have said, I don't want my child to know that they're on the autism spectrum. We don't use that word at home. And I've had parents that are very open. So I think just getting that parent input. And I think at the end of the day, when I do talk to parents, their number one reason is fear.
Mhm.
They don't know like what the future will hold if they use a certain term. And so, I think while the disciplines are different, I think, kind of that idea of getting that parent input and really trying to understand like what is it about these terms that's the parents don't like, right? Is it that they're scared of it? Is it a cultural thing? There could be so many reasons. So, for me, what's worked is like trying to figure out why certain words the parents don't like, and coming up with vocabulary that they're more open to using, and then slowly warming them up to the process of, using some of the scarier terms, has helped for me. So just wanted to throw that out there.
Thanks for that, Sunny. Yeah, I feel like a lot of this is transferable for, I mean, working with children, patients of any setting.
Mhm.
Um, oh, I wanted to see the chat. So does this part education booklets take up the majority of your time as a specialist, or do you carry out the traditional clinical duties of specialists? So I carry out the traditional clinical duties of specialists. I do. I provide, I do assessments, I provide education, procedural support, I play at bedside with patients to normalize the experience for them. I attend meetings. Um, this part of my role is is pretty minimal, I have to say. Like within my hours, thankfully, um, I have worked like a long time with the physician to make this become a reality. So yes, I do carry out traditional clinical duties of a child life specialist. Hi, Vanessa. You're the best. Thank you so much. Vanessa and I collaborated together as child life specialists to create a grief book. She's so lovely. Um, Who normally creates the resources? Would that be a part of our roles as a child life specialist? Great question. I think it's different for every single hospital. I do know within the hospital that I work at that part of the clinical ladder is to update and create resources. And so that is part of our role in the hospital that I am employed in, but I'm not sure how it is for every single hospital. I'm sure it's different for every hospital. Um, Marketing has a lot of input for our resources at the hospital that I work at. Um, and also we have a phenomenal patient family education like team. And so they also provide amazing resources for families. And I often talk to them um, to also get like approvals for this. Like I had sent this information to our patient family education team. Can you suggest that some books that that at for CLS? Um, I'm not sure. Maybe like, can I suggest some books that are like appropriate for child life specialists for teaching? I could suggest many, many books. There are also so many um, resources through other hospitals too that have like diagnosis teaching educational books for patients and families. There are some that are traditionally published. A lot of the books I notice are self-published, um, or they are like teaching materials, like the materials I've created for my team. But if you would like some suggestions, please feel free to email me. Um, Check out Bell Asteri and their Ashland Academy for books about cancer. Yes, there's so many great books about cancer, and they're also different. Like there are certain parts to some books that I feel like can resonate with patients and children and adolescents. And then there are other parts where it's like we can skip over that, and that is okay. Like really catering it to the patient is the best part about helping facilitate this education for patients. Um, what was the resource you identified while speaking about the one-page educational resources? Again, UC Davis. UC Davis has community resources. I think it's under parent resources. If you go onto their UC Davis Child Life page, they have parent resources, and then it's like how to support your infant with hospitalization. And I think that is phenomenal. I think that is so cool that they have that for their population, for the community. I think that's great. Um, but if anyone would like any like follow-up like books that I could recommend, um, there are also many other like websites that do like book reviews for certain diagnoses or even certain developmental levels, like um, and for certain, like for children with autism, or for um, children with um, sensory needs. Like there are so many different resources out there, and I'm happy to compile all of that in one place to send out if you email me. I think that's all the questions in the chat. Um,
No.
I just, mhm.
Oh, we have some questions in the Q&A. So, um,
Oh, okay, great. Oh, wait, how do I access?
on the bottom, do you see Q&A?
Hmm. Oh, yes. Oh, wow. Um, oh, yes. It says, can you show the education materials you have made? I can show bits and pieces of it. Like if you email me, I'll show you a sample of what it looks like. Um, oh, this is a great question. What is an example of a triggering word? Oh gosh. I feel like a lot of words are triggering words. For example, like being a child life specialist in the hospital setting, there are some families and children that do not like to hear the word poke or needle, or even I feel like cancer is a really big triggering word. Cancer, tumor, terminal. There's so many triggering words, which I think are so appropriate. And like Sunny said, I feel like there are reasons to why caregivers and family members um, do not want to expand on these really sensitive topics. Um, and it's really a matter of just understanding where the family is at and understanding from the family where their child is at. Um, how do you handle a family that wants nothing to do with any of the medical team in the hospital? Hmm. In terms of any help or advocacy. Hmm. Um, I would love to hear more information about that. Even just a little bit more information. Um, let me look at the chat. Um, so for any family that just wants nothing to do with the medical team in general, I mean, I feel like the medical team is such an expansive word. Like, here. Some more information. We had a family like that. Nurses told us volunteers don't go in there. They hate us. Hmm. Again, I feel like um I feel like it is okay for families to have like agency to say no. And I think that is okay. As a child life specialist, that is okay for me. I really, really believe in allowing families to choose how their journeys are going to be like. And if they say no to volunteers or any ancillary services or support services, that is very normal. I've seen that happen many, many times. I think that when a family is saying no to nurses coming into the room, I think that there just needs to be like a clear boundary of when the nurse has to go in the room or when the doctors have to go into the room.
I was going to
And
ask to kind of add to that, Joy. Again, I'm not a child life specialist, but when you have families that just refuse a service or they don't want people to go in, do you think it's because they've had a bad experience with maybe like the medical team? Because I've had situations where, my daughter has epilepsy, so, when I talk to doctors, sometimes their bedside manner is not the greatest and it's just like very overwhelming. And so, do you think those experiences could kind of shape the parents rejecting additional services?
yes, and I think that there are so many different factors impacting the reason why family says no. Yes, I do think that it could be a previous experience with certain staff members um, or at a different hospital institution fully. Um, Again, I feel like all of the professionals operate so differently within hospitals. Um, So it could be that, or it could be that the family is already overstimulated and they're just it's not no forever. It's not at this time, and that is okay. Um, I also think that it could be a cultural thing for a family to just want to be supporting their own family. I think that is also okay. And then this participant is saying, if it's cultural, would you try an interpreter in that case, even if the nurses say no? I would say if you are a volunteer, I would say that it would probably be a child life specialist or like a professional that would go in there with an interpreter just to see if the family wants services or not. Um, I feel, and everyone has so many differing opinions on this, but I I feel like as a volunteer, I would want to support like the volunteers that I serve too, and not have them feel like they have to go convince a family that they want volunteer services, you know. So I hope that answers your question. And then someone asked if I can show everyone the book that I created. I can't show the full book, unfortunately. And so again, if you email me and then I'll show little tidbits. Um, Oh, there's another question here. What qualifications are required to become a child life specialist? Are there any certifications or courses you recommend? So the qualifications to become a child life specialist are certain courses, such as an intro to child life course. There's a play course. There's a grief course. There's a number of different required courses. It is required to have a bachelor's. It is optional to have a master's. You have to have at least 100 hours of volunteer experience. It's preferred that you work in a variety of different environments with children who are well and children who are in stressful situations. Um, what else?
I was gonna
And
say
then, huh?
we're also gonna do an open house.
Oh, good.
Our open house
Great.
is actually on June, let me get the date. It's on June 3rd at 5:30 p.m. And so I will also include that link in the email, in the follow-up email. So if you are interested in learning more about how to become a certified child life specialist, our open house webinar will give you all of that information.
Perfect. Thank you so much, Sunny. Appreciate you. Um, yeah, and then there's like practicum, internship, all the things. There's so many different requirements for becoming a child life specialist. Um, for me, I had done volunteer hours and I worked in so many different places. I worked at Ronald McDonald House. I worked for a family resource center. I worked as an ABA interventionist. I, um, and then I did a practicum. I got my master's. I did my internship. I did a fellowship. And then I became a child life specialist. So everyone's journey is so different too. And so there's not one like direct path into becoming a child life specialist.
Awesome. Well, I think these were great questions. And Joy, thank you so much for, sharing your experience, your journey as a child life specialist and providing some great insight. Whether you're a student, you're working towards your child life certification, or if you are a child life specialist, I think hopefully Joy's talk today was you were able to resonate with her talk. And we will have this webinar available on our YouTube channel once we make some edits. And yeah, thank you guys so much. And we hope you attend our future webinars. And again, look out for that follow-up email. Thank you so much.